Hi everyone, this is Tracy Koch and I'm discussing Chapter 8, Enzyme and Collagen Disorders. This chapter is pretty interesting. We talk about genetic disorders that are related to enzyme function and also the collagen disorders that are related to the production of collagen. So, starting out at the beginning, the human body as it functions, requires daily genomic activity to produce, maintain, and recycle proteins. It really relies on the cooperation of many systems to keep us balanced, and occasionally this process will be interrupted by an overreaction. Perhaps the mutations will disrupt the production of proteins, that specific enzymes and different types of collagen. Then there's a negative impact on the overall physiologic function of the body. Enzymes are genetic gene products. So an enzyme, it's a biological catalyst. It causes a biochemical reaction to occur. It increases the rate of a specific biochemical reaction within a cell, body, tissue, or an organ. Known mutations in common enzymes results in either the accumulation of excess amounts of specific amino acid, hyperaminoacidemia, or the buildup of a precursor product with lysosomes, and that's a lysosomal storage disease. So there's a little bit difference between the two. Hyperaminoacidemia is when you have the increased amount of the amino acid, and some of those can actually be detected through a urine test. Lysosomal storage diseases are if the enzymes in lysosomes are defective or deficient, then this causes a buildup of a precursor material that can be toxic to the cell. This is a nice diagram that shows that. Here's your precursor substances, normal enzyme action, and your final products. But if you have a buildup of these, your enzyme can't produce, it can't, have that biochemical reaction and produce the product that it's supposed to. So I think this is a really nice diagram to kind of organize it in my head to keep it straight. Common facts. Genetic enzyme deficiencies. Oftentimes, or all the time, neither parent will have an obvious problem. The affected newborn, will not have symptoms at birth. So they feed normally. They gain good weight. They do well in the immediate newborn period. We see this very often. The maternal enzymes will cross the placenta and perform their specific functions in the fetal cells. So it's not till they have that withdrawal of those enzymes that they start to produce symptoms or have an indication that there's a problem. Let's see here. Many enzyme disorders can be cured by hematopoietic stem cell transplantation. So HSCT will be that abbreviation throughout the slideshow here. This procedure is costly and dangerous, as you might imagine. Examples of hyperaminoacidemias: alkaptonuria, cystinuria, homocystinuria, maple syrup urine disease, and phenylketonuria. So again, I'm sorry if I'm butchering those terms phonetically. Examples of lysosomal storage diseases. So remember, these work a little bit differently than the hyperaminoacidemias. Fabry disease, Gaucher disease, Crab disease, Pompe disease, Hunter syndrome, Hurley syndrome, and Tay-Sachs disease, which you all have probably heard that before. PKU. The enzyme PKU is deficient because the excess buildup of the phenylalanine, we talked about that in the previous slides, how there's excess buildup, and that causes a deficiency of tyrosine. So this is kind of a chain reaction, if you will, and you need the phenylalanine hydroxylase in order to process to have the biochemical reaction, and because you don't have the tyrosine, the buildup of the phenylalanine is what causes the problem. I know that I probably just confused all of you, but the thing to remember is it's a tyrosine deficiency that results in the buildup of the phenylalanine. This is an autosomal recessive trait. It's 1 in 10,000 live births. We do pre-newborn screening on PKU. That's the heel stick that we talked about in Chapter 14 for the newborn screening. It's most common in Euro-Americans from Ireland and Scotland. The pathophysiology of PKU is excessive amounts of phenylalanine and phenylpyruvate buildup in the blood and other body fluids. The blood pH is really low. Growth, brain, and neurotransmitter production is reduced. So immediately after they're born, this biochemical process happens. This excess affects the developing nervous system, the buildup of the phenylpyruvate and the phenylalanine. So it affects the central nervous system, or the developing nervous system, and you can see the brain function would be reduced, as would be growth. Signs and symptoms: severe cognitive impairment, a small stature, a small head size, so there's your affected growth, poor motor skills, light skin, hair, and eye color, tremors and seizure activity, and a musty or mousy odor of sweat, breath, and urine. So because of the buildup of those enzymes is what you're seeing the result of with these signs and symptoms. The management is a strict dietary restriction of phenylalanine intake, so less than 300 to 500 milligrams a day. Lifelong restriction is less severe after brain development is complete. There's also some drug therapy that will improve that conversion from the phenylalanine to tyrosine. An interesting fact that oftentimes breastfed babies, they may not show this positive result on the newborn screen for the PKU, so we do another sample 10 to 14 days later to detect that. Okay, moving on to Gaucher's disease. Gaucher's disease is a mutated beta-glucosidase gene, and it results in the excess buildup of glycoceramide in lysosomes of macrophages and other white blood cells. So, your macrophages, your white blood cells, fill up with this excessive buildup, and they aren't able to function. It's an autosomal recessive trait. The incidence is 1 in 450 live births, and Ashkenazi Jewish descent are highly affected. It's also high amongst French Canadians. 1 in 40,000 to 100,000 live births in general. The pathophysiology: there's 2 types of Gaucher disease. Type 1 is non-neuronopathic, the buildup of the macrophages in the liver, spleen, and bone marrow and the lungs, but not in the central nervous system, and this is the most common. Type 2 is acute non-pathic infantile, where the buildup is severe in the central nervous system and it leads to a very early death. And type 3 is a chronic neuronopathic, and the central nervous system is affected, but not as severely as type 2, and that's a very, very rare finding. So of the type 1, the glucoceramide collects in the macrophages of your liver, spleen, and bone marrow and lungs, resulting in organ enlargement. The excessively large macrophages also exert pressure on nearby organ cells, so that changes decrease perfusion and oxygenation, which greatly reduce organ function and shorten life. So let's say that your bone marrow gets infiltrated with these enlarged macrophages, and it affects the normal production. So you're not producing red blood cells, platelets, in what you normally would do with normal bone marrow function. So you get thrombocytopenia, which results in the easy bruising, and that might be what you see when people present with this. Some signs and symptoms when it's not managed would be a protruding abdomen with a large liver and spleen, which would make sense if you're collecting all of those macrophages. Thrombocytopenia, which is the easy bruising, anemia, fatigue, bone pain, osteoporosis, short stature, and premature death. Okay. Management of Gaucher disease, vitamin supplementation, of course, platelet and red blood cell transfusions. You can also use platelet and red blood cell growth factors. Splenectomy might be helpful. Biphosphonates to help prevent bone density loss, joint prosthesis, enzyme replacement therapy, which is actually pretty promising. You need to really focus on the problems that are caused by the disease. Gaucher 1 responds well to enzyme replacement therapy, the Cerezyme, which is an infusion every 2 weeks until you get your desired blood level. So not only focusing on the problems caused by the disease, i.e. the anemia and the thrombocytopenia, but then the enzyme replacement works well for Gaucher 1. Stem cell transplant, the HSCT, as we talked about on the first slide, is pretty dangerous, and the mortality rate is around 50%. So it's pretty dangerous, pretty costly, and there really is no guarantee that the outcome is going to be good. All right, moving on to Hurler syndrome. Hurler syndrome is an excess buildup of mucopolysaccharides lysosomes of most cells, and it's also known as MPS 1. It's an autosomal recessive, and the incidence is 1 in 100,000 live births. Huge amounts of the mucopolysaccharides collect in the lysosomes of macrophages in many cells in the basement membranes between the tissues and the blood vessels. These changes eventually reduce organ function, especially of the liver, brain, and lungs, and shorten life. Signs and symptoms, it's almost identical to Hurler syndrome, but it has a much slower onset and less cognitive impairment. So you have the coarse facial features and the large head, prominent forehead, heavy eyebrows, short neck, short stature, respiratory infections, and premature death. Enzyme replacement therapy with the idursulfase or elaprase. Again, very expensive. Drug therapy to manage your respiratory infections, and the stem cell transplant that we talked about earlier, again, expensive and risky. Fabry disease, or Fabry disease, there's a couple different pronunciations of that. This is genetic lysosomal storage disease. It's also an X-linked recessive, so the excess buildup of GL3 in the lysosomes of many tissues. The incidence of this is 1 in 40,000 to 60,000 live births. It affects males almost exclusively. Female carriers may have some symptoms. The pathophysiology of this is the GL3 and toxic metabolites build up in within the blood and lysosomes of many of the tissues and organs. This leads to the blood vessels being much less efficient. So your efficiency of your blood vessels is decreased, and there's an inflammatory process that goes along with that. So eventually your tissue has ischemia and organ failure. So it's a perfect storm of terrible events. The biochemical changes can be identified in early childhood, and the signs and symptoms often show up later in childhood. So you might have some subtle symptoms at first. Generally, males show symptoms 3 to 5 years earlier than females. The vascular organs, the heart, kidney, and the brain tend to develop more damage earlier, which you would expect. Those are highly vascular areas, and if there's vessel disease, you would see that. So signs and symptoms: cold intolerance, heat intolerance, eye opacities, numbness of fingers and toes, skin angiokeratomas, reduced heart, kidney, and brain function, again, because of the perfusion, renal failure, strokes, hearing problems, premature death within 20 to 40 years. So not as bleak as Hurler and Hunter syndromes, but, no walk in the park for sure. Management is enzyme replacement therapy with agalsidase or Replogel. This drug therapy will slow the progression of kidney disease and reduce reduced brain perfusion and reduced myocardial perfusion. They don't prolong life. So in addition to the enzyme, you also treat the perfusion problems and will reduce the symptoms. The enzyme replacement therapy is really kind of your standard of care, so that should be started as soon as the disease is identified. Tay-Sachs disease is a mutated beta-hexoamidinase A gene. It results in a buildup of GM2 ganglioside in the brain cells. This is an autosomal recessive trait. The incidence is 1 in 3,900 live births, and Ashkenazi Jewish folks are affected. 1 in about 320,000 live births in general. So in your Ashkenazi Jewish population, the incidence is higher, 1 in 3,900. In the general population, it's 1 in about 320,000. I think I was a little confusing on that. The pathophysiology is that you have these large amounts of the GM2 gangliosides collecting in the cells, particularly in the neurons. So this causes them to just kind of enlarge, they balloon up, they lose function over time, and typically death occurs by age 2 years, usually from pneumonia. Signs and symptoms. Problems are typically noted within 4 to 6 months of age. You start out with a child who, as a newborn, is thriving and doing well, and then start to notice some of this loss of progression of developmental motor skills, and eventually there's just no progression at all, and then regression. The hallmark of Tay-Sachs on physical exam is a pale retina, and the fovea will be like a bright cherry red, and that's because the retinal cells have just become filled with the GM2, and it makes it really pale. So as a result, your fovea stands out as a cherry red spot on that background of that pale retina. There's progressive muscle weakness and paralysis, loss of normal reflexes, hyperactive startle reflex, blindness, seizure activity, and then, of course, the premature death. So those are the enzyme disorders, and we're going to move on to the collagen disorders. So the collagen disorders are related to production of collagen. Collagen is a group of different types of glycoprotein fibers. They start as procollagen and form the major part of connective tissue in all of our body tissues. Procollagen is processed or modified in many ways to form different types of mature collagen fibers that work with elastin and fibrillin to add strength and structure to most of our tissues. So this little factoid will come in handy as we start talking about the different kinds of collagen disorders, and on where in this process the genetic dysfunction is. So the genetic mutations of any of the collagen genes usually affect more than one type of tissue. And remember back from the earlier chapters, that's pleiotrophy. It's involved in and are involved in many different genetic disorders. The production of different types of procollagen and its modification steps are, again, genetically controlled. And mutations that affect the production and composition of any type of collagen type or interfere with the modification, assembly, or association with the other molecules results in a collagen disorder. So it's not just about having collagen, it's that entire process. Anywhere in the process you can see the genetic disorder or the effects of the genetic disorder.